Okay, so we'll move on to the next speaker, and Dr. Gleicher will try to tackle one of the most controversial and difficult subjects in our field, which is immunological pregnancy loss.
Okay, and I'm filling in here for Dr. Braverman, who had a family emergency and was initially supposed to give this talk, but to a degree it is really an extension of my earlier talk this morning. So again, conflict statement, nothing of relevance to this talk. I will briefly repeat what I already presented in my earlier talk today, the history of association of pregnancy loss with immune system function, how to diagnose immunological pregnancy loss. In other words, how do we know that a pregnancy loss may be or is likely immune in nature? Again, I will revisit the point that immunological pregnancy loss is not an autoimmune loss, as it is widely presented in the literature, but an alloimmune loss and what that means. And then I will be talking a little bit about treatments. I mentioned the history already that started with Medawar and Billingham, foundation of the American Society for Reproductive Immunology, lupus discovery on the ward that autoimmunity and specifically the presence of the so-called lupus anticoagulant and antiphospholipid antibody is associated with miscarriages, aside of being associated with thrombotic risk. Then we expanded that to a more broader view that autoimmunity is associated with miscarriages, and Giver and associates in Israel associated autoimmunity also with implantation failure. Now, once a patient comes to you and her presenting symptom is pregnancy loss, it is usually not a single pregnancy loss. And if it is, you will probably rightly tell her, sorry, this is bad luck, don't worry about it, the next time you will do better. And you will be right in telling the patient this, unless there is something in her history that suggests to you that she may be at risk for repeated pregnancy loss. In other words, and I think this is an important point to make, history is crucial here, taking a detailed history, because your patient does not have to wait to fulfill the criteria of being a repeat aborter, which is usually 3 consecutive pregnancy losses in the first trimester, or 2 with one being in the second trimester. Your patient does not have to wait to go through all of these negative events if, for example, she suffers from lupus. Okay? If she comes to you even after her first miscarriage and she has a history of lupus, don't wait for her to miscarry again. Don't give her the advice that you otherwise correctly would give to patients, that a single miscarriage has no meaning. Okay? In that case, I think you need to obviously re-evaluate the patient. Now, the reason why the advice usually is that a single miscarriage does not deserve even a workup, because we believe that the large majority of miscarriages are chromosomal in nature, aneuploidy. And if that is the case, it is once again, in the overwhelming majority of cases, a random event, and therefore there's no increased repetition risk. Likely the second most frequent cause of a miscarriage is, however, immune. And once again, same point, while your first assumption should always be that it is chromosomal, don't forget that the second most frequent cause is immune. And this does not only relate to the patient presenting with a history of lupus or of another autoimmune disease. But it also relates to her family history, for example. Okay? If she has a history of autoimmunity in the family, that alone, if you have a first-degree relative with a defined autoimmune disease, statistically, that alone gives you a 40% risk, roughly, of having autoimmune abnormalities in your blood, even if you're completely asymptomatic. So you need to understand that autoimmunity is a highly familial condition, and history is of very great importance. What is also frequently of great importance is the kind of pregnancy loss. And I mentioned that already before. It makes a difference whether you have an early blighted ovum or whether you have a pregnancy loss at 16 weeks after fetal heart. It makes a big difference whether pregnancy loss happens before or after fetal heart. But it makes an even bigger difference whether the pregnancy loss is very early or very late, because even though at any point the most frequent cause of pregnancy loss is chromosomal, the later the pregnancy loss, the less likely statistically is it chromosomal, and the more likely is it immune. And once a fetal heart has been established, the likelihood of any loss after fetal heart increases the likelihood of an immunological etiology very, very quickly and very dramatically. So at our center, when we are getting our basic history from the patient and she tells us about a miscarriage or multiple miscarriage, there's always a very detailed note as to when that miscarriage happened, and the more miscarriages after fetal heart or the later her miscarriages were, the more do you have to suspect an underlying immune problem. Miscarriages obviously also can be anatomic, and I don't have to tell you that that can be easily investigated. And then there's obviously a plethora of other causes, not the least chromosomal abnormalities in the parents, balanced translocation that can become unbalanced, etc., etc. So, in general, the recommendation for an immune workup is, as I said, once a patient is established as a repeat or habitual aborter, 3 first trimester or 2, 1 first and 1 second trimester pregnancy losses. But those are not ironclad rules. Individualize and rely on the history you're obtaining. It is also important for you to understand that whatever ultimate diagnosis you reach, in other words, whatever your ultimate conclusion is about the likely etiology of a patient's pregnancy loss, it is always a tentative one, because we do not have proof. I cannot tell you to do test X to confirm that is an immunological test. But I also want to tell you that the presence of a chromosomal abnormality is also not proof that the pregnancy loss is chromosomal in nature. Indeed, there is significant evidence in the literature, mostly in the autoimmune literature now, that the presence of autoimmunity in the mother appears highly associated with an increased aneuploidy risk. So we used to believe that if we send products of conception after a miscarriage and get a report that says that this is a chromosomal abnormality, we can automatically exclude immunology as a cause. It has to be chromosomal. That is not true, and it is particularly not true if the chromosomal abnormality that is being reported to you is one that is compatible with life. So be careful in making those automatic assumptions. So as I said, there are no diagnostic tests that are accurate. We always make an educated guess. That's as good as we can do it. And please also remember that sometimes there can be more than one cause. A patient with lupus may have an unemployed pregnancy. And I mentioned that. Now, coming to the theme of immunological pregnancy loss. I mentioned in my earlier lecture the basic biological fact that the fetus is an allograft, a semi-allograft. It is like the woman is receiving a little mini solid organ transplant from her husband. And if that were indeed to happen, she would reject it. Yet, a woman with a normal immune system, as I mentioned earlier, does not reject it. And I also mentioned that that means that a normally functioning female immune system allows implantation to take place because of an innate capability of her immune system to induce tolerance pathways. In other words, something is happening to her immune system that kind of throws a switch and reprograms the immune system from rejection to tolerance. And I also made earlier the point, and it is a very important point, that that does not mean that this immune system per se becomes insufficient. 30, 40 years ago, we used to believe that pregnant women are at increased risk for certain infections because of their ability now to tolerate that pregnancy, that those processes also affect the ability to withstand certain infectious diseases, etc. Today we know that with very few exceptions, that is not the case. Those few exceptions are probably pathogens or parasites, as I mentioned earlier today, which induce similar pathways to the pathways that are required for a normal tolerance of the fetus. And I also made the point that this tolerance is unique because it is time limited. Now, I told you earlier that I would go a little bit more into the induction of tolerance. And it is important for you to understand that the tolerance that is induced in a normal pregnancy is a stepwise process. And the first one is innate. It is probably initiated already long before that little embryo is trying to implant, simply by intercourse. The semen that enters the woman, her vagina, her uterus, and therefore is exposed to the mucosa, which has a very active immune system, the partner's semen carries HLA antigens, the same HLA antigens that make the implanting embryo allogenic incompatible. Therefore, with great likelihood, just that exposure already induces these immune tolerance pathways in a woman. How do we know that? We know that actually for quite a long time period, many decades, because many decades ago it has been demonstrated that conditions which now are quite clearly understood to be abnormal tolerance, like preeclampsia and eclampsia, or premature labor for that matter, are much more frequent in first pregnancies, meaning less exposure, sexual exposure before, are much more frequent in second pregnancy with new husbands. So this initial induction step of immune tolerance probably happens already quite a while before the embryo implants, and probably also is further enhanced by the implanting embryo. And this is, as I mentioned, an innate process that every woman has, which, if her immune system is working normally, will establish all the necessary tolerance for that embryo not to be recognized by her immune system as being foreign. Now, you also probably, those of you who treat patients with immunological pregnancy loss, you know that if you have such a patient and you succeed with your treatment to get her over the initial hump, meaning the time period where she usually miscarried. And I always ask my patients who have miscarriage problems, what was the latest date of your miscarriage? And this is an important question because it tells you for how long your patient will require treatment, and we will be talking about treatment in a minute, how long you need to maintain her treatment, for how long you have to suppress her hyperactive immune system. If you succeed in doing that, and if therefore during that risk phase where she had her earlier miscarriages, if she does not again miscarry, if the fetal heart is not again lost, then you will find that if you follow her immune profile, that it normalizes. If she had antiphospholipid antibodies, you will see that they come down and they disappear. In 35 years, I have seen only one patient in my own practice who did not normalize in the second trimester. And we follow those patients very, very carefully. So in the second trimester, if you get her with an initial hump, suddenly everything goes smoothly. And there's a reason for that. And that reason is that a secondary tolerance mechanism kicks in. And that mechanism is called microchimerism. I don't know if you have heard about this, but this is a concept that was first described by Startzel, who was one of the liver transplantation pioneers in Pittsburgh. And he demonstrated that in the early liver transplantation experiments that he did, by demonstrating that the graft, the liver transplant graft, will only succeed if cells from the organ, meaning from the donor, enter the recipient and systemically spread through the recipient's bloodstream and implant. And that process creates microchimerism. And vice versa. Cells from the recipient have to enter the donor organ. And think about it. The same thing obviously happens in pregnancy. In the second trimester, suddenly fetal cells are entering the circulation. We use that now for early prenatal diagnosis. But just as fetal cells enter the mother and establish microchimerism in the mother's system, so do her cell enter the fetus. And this mutual microchimerism establishes a second wave of tolerance. And this second wave of tolerance is highly effective. How do we know that? Think about your patients who have autoimmune diseases. What happens with autoimmune diseases in the second trimester of pregnancy? If you go to the literature, you will find they usually improve. If your patient had active SLE, she gets better in the second trimester. And the reason is because the tolerance-inducing abilities of that microchimerism also protect against self. So, once again, all of this is time limited because at a certain point, the combination of innate tolerance induction, the first stage, and that of microchimerism comes to an end because the patients who in the beginning had difficulty developing that innate tolerance also prematurely lose that innate tolerance, and that microchimerism tolerance stage alone is really not enough, just as the innate is not enough. And when you think about the fact how quickly the antigen load that the mother has to tolerate increases from a microscopic embryo implanting to a 7-8 pound baby, it is understandable that at some point every immune system will run out of capacity. And that is probably what gets labor going. So in a way, we are all chimeras. I want you to know that. Every one of us is really a chimera, because till today, we are carrying cells from our mothers in our body, and probably also from our grandparents through our mothers. All right. Now, so what I've told you is that an immune response against the fetal allograft is initiated with implantation. This immune response is either normal or abnormal. If a woman has a normally functioning immune system, she will develop tolerance. If she has an abnormal functioning immune system, she will develop complications, early pregnancy miscarriages, implantation difficulties, late pregnancy, preeclampsia, eclampsia, premature labor, gestosis of pregnancies, etc. What does all of this depend on? Besides what we already discussed, it obviously depends on HLA status of both partners. You know that if somebody gets a kidney transplant, if the donor is highly compatible, there will be very little rejection. The more incompatible the donor is, the more potential rejection will take place. The same can be said about the antigen quality. For example, there's data in the literature that a male implant is much more antigenic than a female implant. So if a woman carries a boy, the risk that her immune system will respond against the pregnancy is significantly higher than carrying a female. The quantity, I think, is obvious. I talked about it. As the fetus grows, as the pregnancy grows, the antigen volume increases exponentially. And the last point, for which I don't have much time to go into, is that there's increasing evidence that amongst the cells that enter the maternal circulation from her pregnancy, maybe the most important ones are stem cells. And that in a way, those stem cells that mothers get from their offspring are used in the mothers for repair mechanisms. So there is not only an immunological purpose for this microchimerism, but there's really a health supporting purpose for that microchimerism. And obviously the timing is of relevance. As I mentioned, the immune response early with implantation is different from mid-trimester and third trimester. I talked about semen, about implantation. What I have not mentioned yet is that there's another very important phenomenon, and that is that as tolerance wears off towards the end of the pregnancy, the woman enters again a very high-risk period. And you all know that from the well-known fact that autoimmune diseases have a tendency to flare in the postpartum period. I mean, the classical one is the postpartum thyroid syndrome. It's the most frequent autoimmune condition in women of reproductive life. But that principle applies to any disease, from cardiomyopathy postpartum cardiomyopathy, to lupus, to rheumatoid arthritis, to MS. The period after ending of a pregnancy, even if it is an abortion or a miscarriage, is highly dangerous for patients with active autoimmune diseases. And I have talked already about the association in late pregnancy complications and early pregnancy complications. Let me close with a little, unfortunately very little, we currently know about how to treat a patient where we finally have come to the conclusion that her pregnancy loss is likely immune in nature. We are obviously trying to calm down the hyperactive immune system in order to prevent the alloimmune response. And this is an old slide that I hand through many, many years ago when we followed patients with known autoimmune findings. Oops, I'm sorry. And what you see here is the time schedule of when you follow their immune system activation. This is not working here. Okay. When you follow the immune system activation, and when we studied this, roughly 80% of the patients who we studied had already evidence of autoimmune abnormalities at the beginning of the pregnancy or before the pregnancy. But 20% were completely normal at that point. But both groups, as you see, shortly after implantation, started flaring their autoimmune abnormalities, at which time we started treating. And as you see, as I described before, very quickly in response to treatment, the immune abnormalities drop. And you see then a second peak late in pregnancy. But this peak is no longer in need of immunological treatment. This we pass on to our perinatology colleagues for treatment. So the important part for us is this peak. And this peak can last a little longer or can last a little shorter. But it is very important that you follow some markers during that time period in determining where the immune system of your patient is. And we use as markers a profile of tests which includes ANAs, APAs, antiphospholipid antibodies, and we use those as a screen every 2 weeks in order to assess where the patient's immune system is. And as I said, if she is in an acute phase of hyperactivity, you will see that she will flare. Then you have treatment that will kick in, and you will, after a certain time period, see that she slowly normalizes. And at that point, you can taper off all of your treatment. Just because a patient needs treatment here early does not mean she needs it throughout all the time. Indeed, 99% of patients, the latest by 16 to 18 weeks, can be tapered off of all medications. The only medication we maintain is baby aspirin, which we maintain through delivery. So let me show you what happened to 10 such patients we followed a while ago. Oops, I'm sorry. So when we followed 10 patients, where 5 were already positive prior to pregnancy and 5 were negative, what we observed that really each one of them, once they conceived, became normal. What does this mean? Became abnormal. What does this mean? That when you have a patient who already has clear evidence of autoimmunity, that autoimmunity will at best remain the same and more likely flare. But even patients who are negative when you test them before they are pregnant, still, with pregnancy, will show significant abnormalities if they are in an active phase. And this is very, very important because, again, these patients are very difficult to diagnose. This means if you have a history that the patient had some autoimmune event, and please remember that the patient who has one autoimmune disease is at greatly increased risk of having other autoimmune abnormalities. So if a patient has an autoimmune history, even if she's negative prior to pregnancy, she has a very high likelihood that as soon as implantation takes place, she will become normal. And this switch occurs before you even have a positive pregnancy test, as we learned in this study. In other words, the autoimmune abnormalities show before day 10, 12 after implantation. And this is what I've just told you. So how do we treat? Patients where we think there may be an immune problem involved in their miscarriage receive baby aspirin. They receive a low-dose prednisone, which means usually 10 milligrams with IVF cycle start, which goes to either 30 or 40 milligrams with HCG for 4 days to cover the implantation period, and then is reduced to 30 milligrams until pregnancy test. If the patient has a positive pregnancy test, she's immediately reevaluated in her immune profile, and adjustments are made. If she doesn't flare, if we're lucky, you can taper her off very quickly. If she does flare, her treatment is adjusted accordingly. Now, we also use, in some patients, blood thinner. I think Lovenox, in some countries called Clexane. And we use in patients with significant autoimmune findings, usually intravenous gamma globulin at various dosages, and if the patient cannot afford it, intralipid infusions. This is our standard protocol. Now, there is increasingly talk, and some people even use experimental biologics, particularly Humira or adalimumab, which is a TNF-alpha blocker, widely used in rheumatoid arthritis and other autoimmune conditions. It is supposedly safe in pregnancy, even though the FDA has not approved it for that purpose. We have only put 1 or 2 patients on it. Some colleagues, for example, Dr. Braverman, who was supposed to give this talk, uses it more frequently. Some colleagues in the UK also use this more frequently. Those are medications that are given by injections. Similar drugs are Enbrel, also a TNF-alpha blocker, and Reproductive, which is an antibody, which is a different working animal. But again, there is very, very little experience with any of these medications. But I would predict that they will come into increasing use, at least in patients with overt autoimmune diseases. Now, a controversial issue is immunotherapy in patients with recurrent pregnancy loss. I'm showing you here 2 recent Cochrane reviews, where the first one says that the outcomes after such therapies are not very good, and the next one says that the outcomes are good. The problem is that the truth is that there are really no good quality studies on any form of immunotherapy in patients with immunological pregnancy loss or immunological implantation failure. It is a matter of belief. I presented to you how we treat our patients. It is completely empirically. I cannot tell you that there is any data that fully supports what we are doing. I can just tell you that those are our best judgments at the moment. The only additional medication that we are using in patients, particularly with evidence of inflammation, is Plaquenil. And with this, I'm done. Thank you very much.